All right. We hope everyone is enjoying lunch and our poster session that's in the back. At this time, I'm going to turn this over to Jenny Hansen, but please feel free to continue eating. Ms. Hansen fills a new role in the Office of Foundation Relations, specifically supporting grants related to diversity, inclusion, and belonging. Prior to joining Purdue for Life, Ms. Hansen was a grant maker for United Ways in Chicago and Detroit, overseeing funding into human service-related basic needs like health, financial stability, and education. So I'm going to go ahead and turn it over to Jenny. Thank you.
Hi, folks. I am just going to talk really briefly about my role here at Purdue for Life Foundation and the way that I am here to help you. My services are very specifically for faculty and staff of Purdue. So if you are not affiliated with Purdue in that way, feel free to continue your lunch, do the New York Times crossword. If you figure out what 34 across is, also please let me know. As I was mentioned, I'm with the Office of Foundation Relations. Our role as an office at the Purdue for Life Foundation is to work very specifically with bringing grants in from private foundations or from corporate foundations a little bit. So we very much specialize in forging those relationships with foundations, helping to connect faculty and staff with them, helping with the actual process of putting together a proposal, stewarding grants that have been brought in, helping to connect if a grantor wants to come to campus, see the work, we can help put that kind of dog and pony show together. And we, in general, can do a lot of work to help research and see what else is out there in terms of grants that are available. We are a tiny but mighty team. I've got colleagues in every who are focused on every department across campus. I get to be very special and focus in on anything that's related to diversity, equity, inclusion, and belonging. So if you're saying I'm a public health equity researcher, well, hey, let's work together. And so what does that mean when I say let's work together? So I am here to help. I am a choose your own adventure book of support. So I can do anything from you saying, here are the keywords of what my research is. Holly sent me an email the other day saying, hey, can you help me find something around environment? Heck yeah, I can. Here's 5 opportunities that we can look at together. Or you can say, I found an opportunity, I'm interested in pursuing it. Let's sit down and strategically think about how to position your research to be the most interesting to a funder. A lot of times, like government funders, they want to hear about what's novel. They want to hear about, in terms of like, what's the backing behind it. A lot of private foundations, they have a very specific thing that they want to fund, and your work can align with it, but you just have to position it correctly so that they see that what you do is exactly what they want. So I can help in that strategic planning process. I can help in the writing. I do anything from you saying, here's 5 bullet points, please answer this question, to saying, hey, they want something on Purdue's commitment to public health and to equity. Can you write up 2 pages on Purdue's commitment to equity? I can do that for you. So boilerplate language I can come in on. It can help with reviewing final applications, editing, all of that submission process. A lot of times, you might be applying to a foundation for the very first time. You're probably not the first person at Purdue to ever apply at that foundation. So I can help provide that background and information of what's their existing relationship with Purdue, what feedback have they given us on the last few proposals. I can also help. There's some foundations that really want to just talk to maybe 1 or 2 people. I can help fill that role and streamline those communications as the funder prefers. Kind of depending on what they need. In general, I'm here to expand your bandwidth. I know all of you are doing really, really important work for this university and this community and this country. I want to help you do more of it and get more resources in to do it better. So I'm here to be a service to you. I don't replace sponsored program services. We still work with them, but I'm here to help you reach out, get more resources in. So there's a little tag for me in your packets today, a little half-pager about what I do and how to reach out. Feel free to connect with me. I'd love to hear more about your research and figure out ways that we can work together. Thanks, folks.
Thank you, Jenny. So this concludes the lunch portion of our day, and now we're moving right into our next panel. Rural Health Equity, Celebrating Hepatitis C Successes and Exploring Opportunities with Indiana Leaders. I would like to welcome Dr. Randy Hubach, Dr. Daniel Rusniak, and Deb Nichols to the stage at this time. Dr. Hubach will be moderating this panel. Dr. Hubach is the department head of the Department of Public Health here at Purdue. He is also the director of the Sexual Health Research Lab at Purdue and associate professor of public health. As a behavioral scientist, he has gained practical understanding of the challenges associated with the delivery of public health programs and that are scientifically sound and responsive to the needs of diverse communities.
Thank you so much, Nicole. And thank you all for still being here and back with our posters. It's great to see our students. I have two wonderful colleagues to introduce. One I only know because everyone says Dr. Dan. So I want to introduce is Dr. Dan, the famous Dr. Dan here in the state. Is the Secretary of the Indiana Family and Social Services Administration and was appointed by the governor on August 1st, 2021. And before that was your chief medical officer for FSSA. And as the chief medical officer and one of the leaders during the statewide COVID response, serving as the point person for long-term care facilities, has been in the executive sponsor for the state's effort to return to Indiana's long-term services and support systems, and was the project director for the state's Pregnancy Promise Program, a program funded by Centers for Medicaid and Medicare. And within a grant as well to improve health outcomes in pregnant women and opioids disorders. We also are joined by Deb Nichols, is employed as the Deputy Director of the Division of HIV, STI, and Viral Hepatitis, my favorite division of every entity, at the IDOH. And prior to her current position, Deb served as the Chief Epidemiologist at the Indiana Department of Corrections and has various epidemiology and management positions within IDOH. And so thank you for bringing these two fantastic colleagues as we talk about rural health equity, especially the intersection of rurality and infectious diseases like hepatitis C. And as Dr. Collins was speaking to earlier about the evident need when we think about hepatitis C nationally and the syndemic relationship between HIV, hepatitis C, and substance use, there's a lot of work to be done, and so grateful to have you both here. And so we have some questions that I will pose, but remember you have that QR code that you can also enter your questions in for our panel, and we'll have a couple minutes near the end to do that. And so thinking about since 2014, the national hepatitis C prevalence rate has more than doubled. Can you tell me about Indiana's approach to addressing hep C and eradication?
Can you hear me?
Yes.
Hi, thanks for having me up here. Good to see everyone. So yeah, in 2014, we started to see that big increase, and one of the big things that happened here in Indiana to address the hepatitis C epidemic was the HIV outbreak in Scott County. So as Dr. Adams said earlier today, we had over 95% of people that were tested down there come back positive for hepatitis C. And as a result of that, the Indiana Department of Health expanded viral hepatitis surveillance. So that was the first step of that. And then also in 2015, the syringe service program started. So Indiana was legally allowed to have syringe service programs and really start to focus on harm reduction as a way to bring people to hep C treatment as well as prevent infection. There's several things I'll talk about today, but I'll start with that as the most important piece as we move to address it. Indiana, in case you didn't know, in 2018 and 2019, we ranked first in the country for acute hepatitis C cases. So newly reported hepatitis C cases, first, 2 years in a row. Now that a lot of states have surveillance funding, we are finding more and more cases across the country. In 2021, Indiana moved down the ranking to 9th, but I don't know if that's a good thing or not, because it does mean other states are finding their cases as well. So we need to treat every state as if it's first. So yeah, and then I'll pass it over to Dr. Rosiniak.
Thank you. What she said. Now, one thing I will say, the time in Scott County when Jerome was there, I think that also set us up for how we would work collaboratively as a state to address hepatitis C, HIV, and substance use disorder, which when you go around the country is somewhat unique for us because it wasn't just a health department response, it was certainly a health department-led response, but we recognized really quickly that the vast majority of individuals down there were going to be individuals who were underinsured or uninsured, but qualified for Medicaid. And so they really approached it from how do we bring all the resources in state government to that particular crisis, and how did we get folks signed up, and some of them had to get IDs, then how did we get them on Medicaid, how did we get them on SNAP? Once on Medicaid, once having an insurer, then you had an opportunity for then how do we get folks screened, treated, tested. And so we didn't stop that from a state standpoint with that particular crisis. And I really do give a lot of credit to Jerome and my predecessor in this, Jen Sullivan, who really established great collaborations with the Department of Health and with us, and that has carried over to Department of Corrections and a bunch of different state agencies, because this is not going to be a shock to anyone. Navigating state government is super complicated, and we don't always make it really easy for those in need. And the only way we can simplify that is if we collectively and collaboratively approach that with individuals. So I actually think that is probably one of the best things we've done together. And so when Deb and folks in the Department of Health are thinking about how they can do more outreach and surveillance, we're partnering when how do we make sure that everyone on Medicaid has accessible treatment, that they are screened, that the physicians who care for them are appropriately trained through ECHO and other programs. So I would say that's also been a pretty good approach for us.
Yeah, and I think we have folks even in the room. I know folks from Positive Link, IU Health are here who've had a lot of Hep C care coordination, and we've had those folks out in the field doing this work too, and there's been a lot of efforts to increase access to testing, screening, and course and care. And so, across the programs that have been implemented, what do you still see as priority populations that we're continuing to serve and want to serve more?
I'll start this time and pass it on. I mean, the ones that I think have the most opportunity to really reach and to treat and to cure, particularly with hepatitis C, I think are the Medicaid population in general, in part for the way that we pay for screening and treatment, but also the Department of Corrections. And we had really good collaborations with them as well over the last several years in making sure that medications were accessible, treatment and screening. There's more that we can do, and we still are collaborating with them because sometimes you have folks who leave Department of Corrections partially treated, and so making sure that we've got appropriate structures in place to get folks connected so that we really can get everyone cured. But I think for us, those are two big populations for sure that we're focused on.
Yeah, so ditto that. Yeah, definitely the population that we're focused on is people who have justice involvement. So not only talking about the state prisons, but also our local county jails. And then the other big piece of it is people with substance use disorder and what resources we have for people with lived experience. And then also we have to talk about people who are experiencing homelessness and how do we reach them, and a lot of those harder to reach groups. Now that insurance, people who have good insurance have been able to get treated and cured, how do we reach that next level and the different levels below that?
And I think within all this, we see this intersection with reality of individuals and places that are hard to reach, underserved, under-resourced, and thinking through that lens, especially the intersection also with substance use, how, especially within rural communities, but also in our urban communities, how have these programs impacted Hep C treatment and recovery statewide? What are patterns you're seeing? Anything notable?
You may have better on their surveillance data. I think one of the ways that we can kind of reach folks that are in rural areas, particularly in high-risk populations, is making sure that we embed screening and opportunities for getting tested and connected to treatment in the locations where individuals are going to go. And so for us, one of those areas is opioid treatment programs. And so Division of Mental Health and Addiction which is in our agency, certifies all of the opioid treatment programs. And again, a lot of credit to Jerome and those that preceded me in getting from where we had a fixed number of opioid treatment programs in the state to really significantly expanding opioid treatment programs, expanding accessibility for it. So there are things that we can do as folks who pay for services in those facilities. So one of the nuanced and wonky things is we can bundle payments, right? It's just like insurance. Like we don't have a great ads, we don't have a flow or anyone, but we can make sure that when we're paying opioid treatment programs, that part of that payment really comes with the requirement that we'll do some screening for hepatitis C, and then once we've identified, then we've got programs in place that can help pay for it. So for us, a lot of it is around where do we have places that we already have payment systems in place, and then how do we connect those systems to screening and to treatment. So opioid treatment programs are a great example of the population. FQHCs, rural community health centers, and all of those are another opportunity for us.
All of what he said, and I will shamelessly plug some of the programs that we have at the Indiana Department of Health. So yeah, working with FQHCs, community health centers, but also our partners that have the boots on the ground. So not only at the syringe service programs and our non-syringe harm reduction sites, but places like Positive Resource Connection that have people go out into the community and go to where the people are that need the services. And we do have a program at the Indiana Department of Health in partnership with the Health Foundation of Greater Indianapolis and the Damien Center called Connect to Cure. There are flyers in the back if anyone's interested. And what this program does is it has linkage to care coordinators specifically for hepatitis C. There's 20 of them placed across the state, and they will help people who are living with hepatitis C or at risk for hepatitis C to get testing, to get that linkage to care, to work on those things that may be barriers to getting that treatment. It started in 2023, and that impact has already been tremendous. They have 106 people already that have been starting on treatment, and then we have 50 people in that program that have already achieved SVR. So we're talking in a very short amount of time. All of the people that are part of this Connect to Cure program have the option and opportunity to become community health worker certified or peer recovery coaches. So, using and utilizing the experience of people with lived experience is going to be critical as we move forward to get to elimination of Hep C.
One other program I'll mention, you reminded me of that we did as well when you start thinking about accessing people who are particularly outside of the urban areas in Indiana was the Project Echo. And really, a national program out of New Mexico that we adopted a while ago. It really starts to branch out to how do we make primary care physicians and other folks in rural areas who may not, have large patient populations with hepatitis C more comfortable in screening and much more comfortable in treating. And, certainly particularly when the direct-acting antiviral agents came out, there was not a lot of experience out there with rural physicians and primary care docs treating it. And so that program as well that was really coordinated through Department of Health was really helpful. Because now that we have lots of experience with them, it's not a really complicated thing. It's not a really complicated treatment. And so making people feel comfortable when they've got, 20 or 30 people that they're screening through in a day to have that conversation and get that testing was also, I think, a really important program that you all led.
And I really appreciated the thought about the care coordinators and Connect to Cure initiative. That's also a unique partnership with Purdue, in some entity that being able to have folks get licensed or certified as a community health worker. So Purdue, we received a HRSA grant a couple of years ago, and we've trained 124 new CHWs that are working in rural underserved populations throughout the state within the last year and a half, and being able to use those funds to then train people with lived experience who can directly go back into those communities and address some of these emerging health issues, but then have the trust of folks within that community too. And so as we talked about those with lived experience, how are they helping to shape programs that we're developing, and how are they kind of a source of valuable data that are informing our public health efforts?
I'll take this one. So one of the big programs that we have since 2018 is the Indiana Peer Education Program, ECHO. So it's this model that Dr. Rosiniak was referring to, the Extension for Community Health Outcomes. We replicated New Mexico's peer education program here in Indiana in 2018. And what it is it's a peer-led model, and it is for people who are currently incarcerated. So people who are incarcerated in our state prisons are trained to be public health educators. One of the main diseases that they focus on is hepatitis C, but we also cover other programs or other diseases such as HIV. But the main push of the program is to talk about harm reduction. And nobody wants to hear me go into a prison and talk. Who am I to talk? So the people that are incarcerated are trained. They're also paid for their job while they're incarcerated in the state prisons. And they do 10-hour workshops to talk about this. Since its inception, we've rolled out into 9 of the state correctional facilities. We've trained over 300 peer educators who have in turn trained and hosted 10-hour workshops for over 3,000 people. That is coupled with the Indiana Department of Correction universally treating everybody for hepatitis C. So as we're talking about how do we increase people wanting the treatment and talking about that it's not, the scary interferon treatment, it's pretty simple now. There's a lot of that stigma that's out there. So, we're using that, but then also that prevention model. And how can we talk about harm reduction with what they have available in the prisons? One more step after that, we've developed the OutPEP program. So we have InPEP, and now we have OutPEP. And this is where, if anyone here is interested, we have a group of people who were part of InPEP. They've been released from prison, and now they go out into the community, and they even go back into the prisons and lead the program. But we can offer that service for free to anybody who would like the same kind of education, the harm reduction, Hep C, STIs, all of this. So we have that at no charge anywhere in the state. So again, having that peer-to-peer education and people who have been trained, they also are community health workers. A lot of them are peer recovery coaches. So if anyone is interested in that, again, please let me know and I can hook you up. Our partners with that are Step Up Incorporated and the Indiana University at Indianapolis Echo Center and the Indiana Department of Health.
Only things I'd add on that from our perspective is paying for peers, which having the mechanism to do so we do in Medicaid. The other thing we've done in our Division of Mental Health and Addiction is, as a state, as we start looking at really crisis response, which is not directly Hep C related, but connected because a lot of the individuals are going to be the same individuals who have substance use disorder and who have Hep C, is we have embedded into our model of crisis response and our mobile crisis teams that there is a peer. And so for the same reasons, it is going to be far more effective at getting folks identified and connected into treatment and then recovery, and then in recovery to cure, particularly around Hep C, if we've got those peers embedded into those systems.
Oh, fantastic. I mean, we've seen how community health workers, peer educators have been vital in every health sector, and how we could then embed them more and more. So I think there is this need, and drawing on their experience and understanding their own path. And I think engaging the Department of Corrections, and then if we're thinking about health equity of when folks are coming back into the community, how do we break some of these cycles, and being able to provide pathways for positions as a peer health educator, recovery coach, are become so vital. You guys have mentioned a lot about partnerships, and I think in order to achieve health equity, we're going to have partnerships across the academic, the community, the corporate, et cetera, governmental. And so how do you see these partnerships impacting the success of the programs that you have? Have there been partnerships that stick out most, or are there partnerships you're hoping to still see?
Me again. Partnerships is one of those 3 Ps that I talk about, peer education, prevention, and partnerships. And we can't do anything from the state level without those partnerships. So we have, our existing partners. We also now, with the Health First Indiana, have expanded our partnerships with the local health departments. Our community-based organizations, those are the ones that are out there doing the work. They're the ones on the ground, making sure that we support them, not only with a workforce that is trained, but also with the funding that they need to do the work. Some future partners, as I have moved back to the Indiana Department of Health, is leveraging data sets with our partners over at FSSA to work with them and the Indiana Health Information Exchange to work on large data sets. And that the partnership with Purdue, even like the Data Mine project, is a perfect example of how we can use those partnerships. And I'm thinking specifically about the hepatitis C care cascade. And then how can we look at that for micro-elimination efforts and then overall elimination efforts?
Yeah, as an agency, we don't function without partnerships because if we think about Medicaid, currently serving over 2 million folks, and our Medicaid office is about 140 people, so they would be really busy without partnerships. So we have lots of partnerships. Certainly we have the provider network, but in Indiana, Medicaid is administered 85% of folks on Medicaid are administered through a managed care entity program, and that is with the 5 insurance companies we partner with, Anthem, United, CareSource, MDWise, and MHS. Like those become really important partners, and we can, through those partnerships, we can incentivize and we can direct for outcomes that we are certainly interested. So that has been a big part for us, at least in the Medicaid side of things, of making sure that they, which have thousands of folks that they employ and interact with the Medicaid population directly, are either if we're incentivizing screening or incentivizing testing. The other partnerships, and we've mentioned, are certainly in the academic world. One of the things that we have unique in Indiana is what we call our WISE partnership, and I know Sarah Weehee was here today. Dr. Weehee has been an integral part of that, and that, I think, for us has been a very unique thing. It was created in 2020, and in part at the time it was, we would reach out to our academic partners occasionally for help. And again, not surprising, in government, it can be cumbersome and slow to do contracting and to get through that process. And sometimes by the time you get through the process, the need is already passed or the opportunity is passed. And so in partnership with CTSI in 2020, we really created this WISE initiative, which would allow us a really fast way to identify a specific need, a specific academic partnership, and then to bring them in. And so certainly ECHO is a program that we've done through that. The whole pandemic response for us really in many ways expanded our use of WISE, and I think we've had somewhere 60 or 70 or so different projects that we have engaged with them along the way. So that, I think, is unique for us, and the great thing, and I just probably mentioned earlier of WISE, is it's not just IU, it's Purdue, it's Notre Dame, and so it really gives us as a state a much broader range of experts that we can draw from. I can remember at one point in the pandemic talking to somebody here in engineering about airflow in nursing homes, and so whereas at times we need a health economist that we, maybe reach out down to Bloomington, at SPIA, et cetera, so.
Yeah, I mean, you bring up the importance of partnership, and it's the head of the Department of Public Health. My emphasis is really community academic partnerships, and communities be at the center. And so within our programs, a lot of faculty here were integrated through extension or through community-based organizations to really be on that forefront. And as we were talking earlier, and hearing Dr. Collins, Dr. Adams discuss, our rural tribal communities are vastly impacted by hepatitis C. Before coming to Purdue, I was in Oklahoma for 7 years and was meeting with Cherokee Nation. Cherokee Nation kind of has led, the tribes are leading the way in some regions where they now have universal screening for HIV, hepatitis C. Anyone that's positive gets treated. Pharmacists, nurses can prescribe pre-exposure prophylaxis for HIV. And so these partnerships, I think, allowed us to keep building within our communities and within government as well to meet those needs. And so as we see folks here in the room who maybe haven't thought about Hep C as your interest area, your passion area, we have some faculty, I think Monica Castine had to step out, who's looked at a lot about testing among vulnerable populations and older populations too, of how can we start to normalize these conversations to get people screened and also then into treatment and care too. But kind of building off of that, are there needs that you see that maybe academic partners could start to fill that haven't been tapped into yet?
Yeah, so one of them that I just mentioned before was utilizing programs such as the Data Mine Project. One program at IU Bloomington is having the nursing students go visit syringe service programs. What does it look like on the ground? So as we are building not only our provider network, but our academic partners, let them see. Who better to show you than, again, people with lived experience? Let them talk to you, learn from them. Don't make decisions. It's been mentioned a couple times today that not about them, without them. Let's go work with the community and not for the, or, make those decisions for the community, which does bring me back to the ZIP coalitions. So Indiana does have an elimination plan for hepatitis C. It was implemented in 2021, and we have 10 ZIP coalitions around the state, and this is one of those fantastic ways that our academic partners can get involved in what's going on at the local level for hepatitis C elimination. There is a QR code up there if you're interested in joining, by the way. And what that is we have advisory councils at each of the 10 ZIP coalitions. So it's community partners, it's local academia, it's those people who live in the community that are making those decisions about their community. And also they can apply for funding through that. One of the big things with the Connect to Cure is how did Connect to Cure decide to put 20 care coordinators across the state? They did not make that decision at the state level. They took it to the ZIP coalitions and had the ZIP coalitions make those decisions of where that resource would be best based. So again, I can't say it enough. Academic partnerships are great. Just make sure you're including people with lived experience along every step of the way, because they're going to be the ones with the resource. And, they may not have the numbers data, but they have the knowledge and the anecdotal data that can sometimes be just as important as you're making those decisions.
Yeah, the only thing I'll add is communications help. I think awareness is really the biggest need, and certainly I think we've all seen in the last 4 years the power of good communication and the challenge of bad communication. And so when we start thinking about in state government particularly, we're all going to be mired in the work and not having enough time, resources, energy. So having folks start to think about how best to convey a message around getting tested for hepatitis C. So like we had a large marketing campaign that we paid for in the state on Check, Care, and Cure. And it probably had some impact, but not the same type of impact that we see. The traditional way of communicating with an ad or a billboard still has a role, but it's changed so dramatically with the way we communicate today in local communities and the way we communicate through social media. So thinking creatively, I think, around how do we better communicate in a way, to your point, that folks will understand, because I can talk all day about these things, but most people will gloss over. That's probably most of you are, on the topic. And so I think that's another area we could use a lot of help with from our academic partners.
Yeah, I think those are needs, and I'm glad we brought the ZIP coalition. So those who are in the Purdue area, ZIP coalition number 4 is our region. I know Jenny Brown, who's in psychology, is on it with me as well for HIV and Hep C program planning. But there's a lot of need, even from students who are interested in those areas, or just folks within the community, of what are you observing, what is your experience, and then how do we start creating a culture where we could have discussions related to these topics too. I did want to open up, I know we have a couple minutes left, to see if there are any questions that have popped up. Give a second for the mic to come on.
What is the role of county extension and local pharmacists with hepatitis C treatment and prevention?
The first, I don't know that I can comment on, but it's a great, I've never thought of it, so it's a great thought, particularly as folks intersect with local extensions. The pharmacy, I do think, has a particularly big role as we start to think about how we change what we typically think of as pharmacy. So one of the big challenges in all of rural medicine is access to a physician or to a healthcare provider. But in the state and generally around the country, everyone has access to a pharmacy within about 5 minutes. And we certainly have seen a shift towards even things like vaccination programs to moving towards what is accessible, which is a pharmacy. And so I do think it's a really good point of contact for folks in rural areas and around the state as we think about creatively, like how might pharmacists, from an awareness standpoint, be part of the conversation, and really you can think about in the future, how might some of those pharmacy embedded clinics really start to be places that do some screening, how might those pharmacy embedded clinics in the future even be places that get folks connected to curative therapy.
I would just add about extension a little bit. I think we are unique as the state-serving institution, because it's sometimes land grant, we has its issues. It's a term sometimes. We have, extension officers in every county within the state of Indiana who have built those relationships and are providing education from finance to health to the health of our crops to really understand what are the local needs. And I think too often we haven't always leveraged extension as much as we could. And I think you guys coming from another state-serving institution, our extension folks are fantastic. We've met with the local folks on the ground. They were willing to address vaccine hesitancy. They've been willing to address every health issue that has been presented to them because they have that vested interest too within it. Michael?
My question wouldn't fit in the number of characters we were allowed, so I apologize. Speaking of extension, I'm a program leader for community development within Purdue Extension, and in one of our eastern counties, our extension educator who's here has been working with the jails and working with the Department of Health. And I thought I heard Dr. Collins say that the VA is using the Hep C cure to cure veterans. 70% of the people incarcerated in that county have Hep C. So what is stopping us from connecting the veterans that are currently incarcerated in that county with the VA in order to get them the cure, at least as a first step?
May have it already. VA has already reached about 90% of veterans and have been very successful in getting them cured.
I won't improve upon that.
How do we help them close that loop? And if 70% of the people incarcerated in that particular county have Hep C, how do we help the board or the health department and the jails work together? Because it sounds like there's a pinch point that's not allowing that cycle to close.
So I would say in Indiana is definitely get in with that Connect to Cure program. And they can work on all of that in that county jail. Yes, county jails are one of our biggest challenges to get hepatitis C treatment in. Number one, because the health care stops once they go in, or there's certain time frames that people can get treatment. People don't want to test while they're in jail because then they do need to get treatment. And that is something that Connect to Cure program can help. Again, working with your local health department, that Connect to Cure program, to see how you can partner with your local jails to get that cure in there. And then one other thing to add too with the academic partnerships is we have the Indiana Hepatitis Academic Mentorship Program. So if you are interested or know somebody who's interested in prescribing Hep C treatment, it's a 2-day program to begin. So they educate people who are providers. After 1 day, they can go ahead and start treating for Hep C, and then 6 months later, they'll have a follow-up. And then also, you can join the Hep C Echo, which is every other Thursday from 12:30 to 2 to get that, the hub team, who is gastroenterologists, a couple of them from Stanford University. We have pharmacists on that. We have social workers on that. Our viral hepatitis services coordinator and our prevention coordinator joined that for some epidemiology support as well. So again, just as that academic partnership with the jails, using anything that you can to get in, because the jails are the biggest challenge. So I really appreciate that question. Again, DOC is universally treating everybody and offering yearly testing for Hep C, but jails, we've not even been able to crack that yet.
I think we have a moment for one more question if there's one in there.
If a community does not have a syringe service program, how can they best begin to address hepatitis C testing and treatment at a local level?
It's probably a two-part answer. One, they're going to have a local health department. And I think particularly with Health First, as we really provide a better framework and structure to support local health departments to do outreach and to do, I'm giving your answer, to do education programs. I think that is actually a pretty good place to go. I think also in any local communities, if you have a rural health center, community mental health center, or an FQHC in those areas, that is also another really good place to kind of look at to start. Any other?
Again, those ZIP coalitions. So reaching out to the ZIP coalitions. Again, you can find out if you're not from this area, which ZIP coalition you're in. There's papers at the back. There's the QR code that is there. But also reach out to your local health department or the State Department of Health to get that data to support what you need for the syringe service program. Don't be afraid to ask for data, and also have that data stratified by different populations, because maybe it's not in just the general population, and you can stratify down until you find that data evidence base to support the syringe service program as a step as well.
Thank you both. I think we're just about out of time. So thank you, Dr. Dan and Deb. Appreciate it.
Thank you.
Thank you, Randy. So now I'd like to roll right into our last panel of the afternoon, and I'm going to introduce and welcome Tisha Reed, who's going to moderate this panel and make all our introductions. So Tisha is the lead senior health equity analyst for Purdue University, Reagan Street Center for Healthcare Engineering. In this role, she oversees Purdue University's health equity work for systems policy change across the state of Indiana. Tisha works with community stakeholders to address health disparities, facilitate strategic action plans, and implement process improvement strategies to improve health-related conditions within their respective communities. Additionally, she provides training for clinical, social service organizations, local governmental agencies, and others to build organizational capacity, promote humility, and address the social drivers of health. Prior to coming to Purdue, Tisha was the lead of health equity and cancer control for the Indiana CTSI's Connections in Health project, and the cancer liaison for the Indiana Comprehensive Simon Cancer Center. So take it away, Tisha.
Thank you, Nicole. I know that now I'm standing not in between Taylor Swift and our keynote speaker, but probably after lunch, you guys might be just a little tired and ready to hit the road. So this is our last panel, and so I'm excited because we've had some great speakers today. Would you agree? Yes, we've had a great time. So happy to have Dr. Leslie Amonu, who is the founder of Millennial Beacon and co-founder of Health Tech Center for Inclusive Innovation. He is currently serving the South and West Side of Chicago as a family and community medicine resident physician at University of Illinois at Chicago, and also in the medical district. He currently serves on the Illinois Legislative Black Caucus Foundation's Health Brain Trust. So please welcome him to the stage. And then our next panelist is Kier Kreitz Moeller, who attended Purdue University studying hospitality and tourism management. She has joined Food Finders Food Bank as its first program coordinator in 2010, launching and growing programs to meet demands. Kier was promoted to Chief Operating Officer in 2015 and moved to Chief Engagement Officer to lead COVID efforts in 2020. Kier is proud to now serve as President and CEO of the Food Finders Food Bank and is actively engaged in our community, serving on the board of the Long Center for Performing Arts, Purdue Center for Rural Education, and the Governance Committee for Lafayette Transitional Housing. Please welcome Kier to the stage. Next is Victor Garcia, who is the President and CEO of the Food Bank of Northwest Indiana in Lake and Porter counties in Indiana. Prior to his appointment at the Food Bank, Victor's experience in nonprofit executive leadership includes roles as the Vice President, Strategic Partnerships at Mental Health America of Northwest Indiana, as well as the Northwest Division Director for the Indiana chapter of the March of Dimes. Currently, Victor serves as the board president for Feeding Indiana's Hungry and is a member of NIPSCO's Community Advisory Panel and a member of Purdue Northwest Hispanic Serving Institution Advisory Board. Please welcome Mr. Garcia to the stage. Lynn Herr is the Director of Clinical Outreach Divisions of Vanderburgh County Health Department. She has been integral in the success of the county's Pre-to-3 home visitation program. She secured funding for other projects related to infant and child fatality. Lynn is a leader in Vanderburgh County Health Department's journey of becoming just the third county in the state of Indiana to be an accredited health department. Please welcome Lynn as well. Ms. Stephanie Long is the President and CEO of North Central Health Services, serving the organization since January of 2015. Before joining NCHS in 2015, she was the Chief Executive Officer of Indiana University Health White Memorial Hospital from 2010 to 2014. Ms. Long is a fellow of the American College of Healthcare Executives. She is a board member for the Wabash Heartland Innovation Network, White County Community Foundation, Indiana Professional Management Group, and Westminster Village. Please welcome Ms. Stephanie Long to the stage. At this time, as you have heard, we have the QR code, so please, as the speakers speak in this order, and they share a little bit about themselves and everything that you would like to share, please go ahead and do that. But I have a few questions first to get us started, if that's okay. So to Leslie Amonu, could you talk about Purdue's strengths and how they are appropriate partner for your organization?
Absolutely. I think, don't take this wrong, I think one of those strengths is the fact that there's not a med school here, right? And there's not a hospital system here, so I think Purdue's very nimble. Mm-hmm. One of the things that Purdue has an advantage is the interdisciplinary collaboration between departments, right? Yeah. And so recognizing the similarities between urban and rural pathologies, right, mm-hmm. is a place where we've been working together and trying to advance innovation. Awesome.
Can you also give an example of a project that you're working on or hoping to start soon, you know, where this community academic partnership can really flourish and be mutually beneficial?
Absolutely. I think one of the things that is missing is hyperlocal data, right? Being able to access data and get it to startups, industry, academia, to be able to deploy it to communities. And then also not just taking data from community, but mm-hmm. also having community investment vehicles where that data is returned back to the community so they can use it for their own advancement, right? So being able to get that data real time and having that supercomputing capability, I think is going to be very, very important and one of the areas that we're looking to really, really push.
Okay, great, thank you. Kier, you have transitioned to the role of CEO of Food Finders during the height of the COVID-19 pandemic. How did the COVID-19 pandemic impact your work and programming at Food Finders?
Yeah, that was wild. I remember that day so well. It was like March 13th, Friday. All of our Purdue groups, like everybody was dropping like flies as volunteers and things like that. So we didn't know what was coming. I think the neat thing that came from that time was that we really were able to specifically just focus on the work. And it really helped us to really hone in on exactly what matters, which was just getting food out to people. There kind of wasn't all this other noise and meetings and, all those types of things going on. We really were just out there doing the work. And since then, a lot of interesting efficiencies and things like that have come through from that time. But honestly, the biggest challenge right now, post-COVID, is that the need is still so high.
Yeah.
And I'll talk about that in my presentation a little bit, but the rate of food insecurity is higher than it has been in years. And we're really just still trying to get to that point and just making sure people still have the resources they need, but also working on all the other root causes of hunger as well.
Thank you. Victor, did you want to add anything to that as you think about food as medicine?
Sure. So I think one thing is, as we talk about food as medicine, I believe food as medicine is the intentional partnership between a healthcare professional and the food bank system to provide nutrient-dense foods to the food insecure population with an underlying health condition. But I think in order to have that conversation, we also need to level set on what a food bank is and does, because there's a lot of misunderstanding on what we are. A lot of times people think of a food bank as a food pantry, and that's just not true. So they're two very different organizations and entities. So if you think of a food pantry as a grocery store and a soup kitchen as a restaurant, we're the supplier. So our core business is warehousing and logistics, and what that positions us for is being able to customize interventions with healthcare partners for specific health conditions. So we've been very fortunate to have a strong, robust partnership with many different healthcare programs in Northwest Indiana, but it's very unique and very challenging. But food as medicine is it's such a critical thing. And I will also argue that food as medicine is almost a repackage of things that the food bank system has been doing since its inception. Most of our products are coming from the USDA commodities through the Farm Bill, the Emergency Food Assistance Program, or the Commodity Supplemental Food Program, are all nutrient-dense programs.
Yes.
Nutrient-dense foods, they're meant for the food insecure population. The difference is that intentional, meaningful partnership between the healthcare partner and the food bank system.
Great, thank you. I'm going to go backwards to Dr. Amona and see if there's, did you want to speak more about what your work is and what you do? Yeah.
Is there a way I can advance the, my slides coming up?
Is it not working at all? Here we go.
Okay. So I represent Millennial Beacon. I work at a large hospital, and we also have several FQHCs affiliation. And we formed Millennial Beacon because innovation simply was not getting to the community, right, when it comes to South and West Sides. And at the heart of our mission is a life science engine that eliminates tragic health disparities while revitalizing community through prosperity and opportunity, right? And so at the heart of our mission is advocacy, but also the community. And so when a patient shows up, this is what they typically look like, right? They're coming in with heart disease, cancer, diabetes, stroke. You can swap out COVID-19 for opioid use disorder. And that life expectancy, you can see just within a mile radius how vast and different it is, right? And so when we typically get a patient, they don't come in with just one of these problems. They come in with 3 or 4 of these problems. So as an intern, when the ED called, my stomach would get in knots, right? Not because of the work we had to do, but because between the time you left the call room, you took the elevator to the ED, you took off your physician hat, and you became an advocate, right? Because that patient that they're calling you about that has a hemoglobin of 6, has been having blood in his poop for 3 or 4 months. Not only do you need to transfuse him now you got to call gastroenterology and say, you need to scope this patient because I might not see him for 3 or 4 months, right? Same thing with somebody that comes in with edema going up to their thighs that tells you, I missed my dialysis session because I missed the PACE bus, right? And now I need to be dialyzed. You got to call ESRD and tell them, I know you're busy, but can you find a dialysis chair for this patient, right? So it's about advocacy. And this picture that I'm painting is not too different from the folks you see in Gary, Indiana, the folks that might have only access to a FQHC, or folks that are in the urban population that have access to only one hospital. And so I'm a Chicagoan through and through, and one of the facts about Chicago is deeply segregated. And that's one of the things I don't like about Chicago. But that segregation, you could literally take a line and draw where the healthcare investment is, right? So 80% of healthcare investment goes to communities that have access to strong life science engines, right? And 20% goes down to the south side of Chicago, and Lord knows if that 20% even really gets to us. But what that shows is at the heart of innovation is the institution itself. And what that tells us is that it hasn't been working. And at the end, institutions are very, very important for the advancement of innovation, right? But this model you see here, right, is what we've been using, right? Looking at biopharma, having hospitals and investigators at the center, and then the CROs, and that poor patient got to drive 60 miles. It doesn't matter if you're trying to solve their prostate cancer. It doesn't matter if you're trying to solve their colon cancer, right? They got to drive 60 miles to do this clinical trial. They're not going to do it. So one of the questions that we started to ask ourselves, or let me go back. So when you understand that, then you understand why we haven't been able to move the needle at all when it comes to healthcare disparities. So one of the questions we started to ask ourselves when we talked to the Cancer Center, when we talked to the oncologist, is how do we do this differently? Right? And they told us that we got to be, in community members, they told us we have to be sensitive to the needs of the community and the population, right? So for example, even the fact that you have clinical trials up there. You know, I was on the call with the Cancer Center, and one of the folks from all of us studying that works for the NIH told us, black folks don't like when you call clinical trials trials. They associate trials with trials and tribulation, right? So being sensitive about that, and I named it clinical discovery. Now, I don't want to see anybody on LinkedIn or Twitter coining that phrase, right? But if we're serious about innovation, right, we have to have patients at the center, right? We got to do some of the innovation that Dr. Francis talked about, making sure that we're looking at telehealth, making sure that we're looking at the virtual component, making sure that CROs are putting the patient at the center as opposed to what we've been traditionally doing. And then the last thing I want to say is, when I reached out to the oncologist, I said, what is an area that we can really make a difference? And they said, we don't have enough trials, the number of trials themselves, right? And so if we're being honest with ourselves, and I think there's a lot of honest people here, if any community is suited to benefit from the strong economic engine that's the life sciences, right, it has to include everybody, right? Whether you're doing it in Chicago and Sterling Bay, or you're doing it at the University of Chicago, or whether you're trying to do it in Gary, Indiana, or whether you're trying to do it in West Lafayette, right? True innovation includes everybody. So if you can do me a favor when you leave here, and you can preach the gospel of Millennial Beacon, right? That's a rising tide lifts all boats. And that's what John F. Kennedy said. But when he was talking about that, he was talking about economic development. I think when it comes to innovation, it's just as apropos, right? So if we do innovation, we do it correctly. It's not just about black folks. It's not just about Hispanic folks. It's not just about white folks. It's not just about rural and urban. It's about everybody. And when we do it correctly, everybody advances. Thank you.
Thank you so much. Oh, Kier, I'm going to pass the mic to you, Kier, who will now present.
Thank you. There we go. All right. Hi, everyone. I was asked to speak about our community partnerships and academic partnerships with Purdue. We're so blessed to be in the same community and just across the river. And as I was kind of preparing my notes, it dawned on me on just how much we do with Purdue. We kind of take that for granted sometimes. So first I want to talk about what Food Finders is. Our mission is to provide food and connections to life-stabilizing resources to our neighbors when they need us most. And we do that through 8 programs and about 100 agency partners. And together we distribute more than 12 million pounds of food a year to more than 65,000 individuals across the 16 counties served by Food Finders. So we are very busy. We have a small staff of 38 folks. It's grown a lot in the last several years. But Purdue really helps us to expand that knowledge and those resources and kind of acts as staff sometimes in that sense. The need for work around food insecurity is because hunger is so complex. When people come to us for food, we know there's a myriad of other issues that are going on in their lives, a lot that we've talked about today. Hunger, when people face hunger, they're often struggling with basic needs such as housing, affordable housing, transportation, job training, all of those things. We've been talking more and more about the root causes of hunger because we really need to start bringing that to light. As Victor said, you know, the needs are so great and we can't do it alone. We have to start addressing these root causes and start talking about them because we can't food bank our way out of hunger. And a lot of those root causes are poverty, low-wage jobs, unemployment, affordable housing. That's a huge issue right now in our community, as you all know. And of course, lack of access to health care and systemic racism. Quickly at Food Finders, we often talk, like I said, about food insecurity in kind of two parts of the spectrum. We want to serve people in their immediate time of need when they're first coming to us for food, and we do so with several direct service programs through our agency partners. Those are the food pantries, the soup kitchens, the shelters across our service area. We have a backpack program, a senior grocery program, mobile pantry, and fresh market. I'm not going to get into all the details of those today. But then on the other end of the spectrum, we need to help people become more independent, more self-sufficient, and meeting them where they're at, really, because that looks different from person to person. And we do that through our education program, through SNAP outreach, helping people get signed up for SNAP benefits, and for resource coordination, where we literally walk through and walk along people beside them and help them connect to all these wonderful existing resources that we already have in our communities. Anything that we can do to help them keep from falling further into poverty. So what is the need? We talked about that earlier. When our latest data came out last year, it's always 2 years behind coming from Feeding America, and it said that we have about 65,000 folks in our service area that are facing hunger. And we knew at that time that that was kind of a joke because the data was old, and that's one of our issues. We don't always have access to the most recent data. And the charitable food sector has been kind of screaming and sounding the alarm for the last several years since COVID. Our numbers are higher than they ever have been before. And thankfully, the USDA came out with a report last fall that really confirms what we've been talking about. And the fact is that the number of people living in food insecure households in 2022 increased to 44 million individuals, 13 million children. It's an increase of 31% since 2021 and 44% since 2020. So we're not crazy. The lines at our door, the amount of people that are coming and seeking resources, it's a fact. And we're seeing it, our agency partners are seeing it, our other folks in the social service agencies are seeing it. It's the highest rate in numbers since 2014 and the most significant one-year increase since 2008. So quickly, I'm going to talk about kind of the meat of what we were talking about today, which is our Purdue collaborations and partnerships. I have to give a shout out to one of our agency partners. I don't know if anyone is here from ACE, Campus Food Pantry. They are truly thought leaders in the work of campus hunger, and we're so proud of the work that they do. They have a food pantry near campus that helps meet the needs of the students that are struggling with hunger, which is often, considered maybe not as an important of an issue. Purdue United Way, we have a Food Finders actual student organization that we work with. We have a host of events and food drives. College of Ag hosts our Blue Jean Ball every year and hosts a wonderful food drive for us. PRF, PMO, HTM, we're involved in all sorts of different organizations, and this is just from 2023 through the start of this year. We have several service learning projects going on right now with EEE 472. I'm going to talk a little bit more about that in a second. We're working with industrial engineering on a student capstone project this semester. We have about 5 or 6 members on our board who are Purdue affiliated. We have multiple student projects going on right now, and we work very closely with Purdue Extension in helping our education program and bringing their knowledge to the folks that we serve. And we also rely on the Center for Food Demand Analysis and Sustainability and the Center for Rural Research, Education, and Outreach for support and their expertise. And did I mention volunteers? When we talk about really expanding our reach, the amount of volunteers, we typically use about anywhere from 38 to 41,000 volunteers a year. And Purdue is a huge component in that. We have wonderful professors that choose to have their students come and volunteer with us, so we appreciate that. But last year, 469 unique student volunteers came and worked with us, and they donated more than 2,400 hours to the work that we do. And when I say how important that is, our staff can't alone do all this work, and so the amount of volunteers is hugely important to us. But quickly, what does that do with our Purdue collaborations? And I'm going to kind of highlight a few of the exciting ones that have happened in the last couple years. But they really do help us expand our services through reach, through the 16 counties that we serve. They help us by expanding our education program. They help us through volunteering. But mostly they help us with gaps in knowledge that, data analysis. We have tons and tons of data. We don't have anyone on our staff that's quite skilled in that aspect of pulling that all together or really analyzing it in some of the ways that we're asked sometimes. So we're really appreciative of that. But most recently, one of the best programs that came from a collaboration with a Purdue student was in 2021. We worked with a PhD candidate, Justin Major. He was an NSF graduate research fellow, and he used our data to prove that our resource coordination and our education program were in fact moving our clients away from poverty. Not as quickly as we'd like, but in fact they were actually moving them away from poverty. We are asked all the time by grantors and funders and donors in our community, they want to see that we're not just handing out food and that we are working to shorten the line and that we're helping people to become more self-sufficient. And so having someone like Justin able to go through all of this data that we had and be able to draw those correlations was hugely influential to us and able to help us on future grant applications. We currently have a student named Ishan Selvin. He's a senior right now in Health and Human Services, Public Health and Health Equity Internship. He is having a blast. We have him for the whole semester, so thank you. We really appreciate that. We have him for the whole semester, and he's helping design curriculum and education classes around healthy cooking and using what types of food you can find in our food pantry or in our agency partner food pantries, and doing cooking demonstrations, food tastings, working directly with the neighbors that we serve and getting that information out to them. And more importantly, he's helping us expand this program currently into Jasper and Montgomery counties as well. So we're really appreciative of that. We're working with EEE 472, a community engaged engineering and design class. They worked with us in 2015 when we were in the middle of renovating our current facility. They designed bioswales and rain gardens that were part of our parking lot and our food bank facility. And a newer class right now is coming back through and re-looking at that project and seeing if there's different ways that we can improve upon it. We've worked with English 420 and an anthropology community engagement class last fall that worked with us as we get ready for our new Feeding America contracts. We have new challenges in how we serve the rest of our service area in our community, and they're helping us design templates and surveys for operational response plans to ensure that we have equitable food distribution across there. And I'm currently working with the Center for Rural Research, Education, and Outreach on other surveys. With our education program, we want to make sure that the surveys that we're using with our neighbors are are academically designed and that they're answering the right questions in the right ways so that we can use that data and that knowledge for future grant applications and to show what great work we're doing. So we appreciate all the knowledge and the expansion that Purdue allows for us. Thank you.
So when I was getting my master's degree, I had a class in public speaking, and my professor said, "Don't forget you're the presentation, not the PowerPoint." And with that, I don't have PowerPoints to share with you today. You get to just look at this great-looking face and smile, right? So we have a joke in food banking, and that food banking is this. If you've seen one food bank, you've seen one food bank. And while our core business is always going to be the same in partnering with our agencies, those food pantries and soup kitchens, what we do is often slightly different. So what I thought I would share with you today is a little bit about our Food is Medicine work and how that intersects with some of our academic partners in Northwest Indiana. We started our intentional Food is Medicine work identifying some of our biggest challenges in our community. As many of you are aware, infant mortality is a significant issue in the state of Indiana, and in Northwest Indiana, it is even more significant. So that was our first foray into Food is Medicine programming. We reached out to our partners at Franciscan Health and built upon their existing prenatal assistance program. Their program identifies women who are pregnant and are on Medicaid and gets them wraparound services like parenting classes through Healthy Families or Nurse Family Partnership, and also gets them some more peer support. we thought, okay, if mom is on Medicaid, she's likely food insecure. So what kind of foods should mom be eating for a healthy pregnancy? And so we built a medically tailored box of groceries that we then delivered to Franciscan Hospital so that when mom came for her doctor's appointment, she went home with the foods that she should be eating. And we saw so much positive feedback and success in that program, we started thinking, well, how else can we leverage a program similar to this? So the next thing we did is we went to our friends at Methodist Hospital in Gary and Maryville and said, what is the biggest issue you're seeing? And for them, it was heart disease. So we worked with their dietitians and their doctors, and we built a box of groceries specific to heart disease. And so we have a medically tailored box of groceries, same model. We deliver it to the hospital. When a patient comes to see their doctor, if they're screened for food insecurity and they have heart disease issues, they go home with a box of groceries. That went great. How else can we help out? Next, we tackle diabetes, same process. You tell us the product, we will go find it, we'll go deliver it to you. Let's meet the patient where they're going to be anyway, instead of having a referral source where the doctor or the practitioner is identifying someone is food insecure with an underlying health condition, and now we're telling them, go to the food bank, go to a food pantry, go here, go there, go to this social. No, let's get them where they are already. This has been working very well. Now, one thing that's unique about our food bank in Northwest Indiana is we are very excited to pilot projects. We are a member, as is Food Finders, of the Feeding America network of food banks. There are 11 Feeding America food banks in Indiana serving all 92 counties. We all work together really well, but we all have our own service areas. So we serve Lake and Porter counties, and through Feeding America funding, we were able to partner with VCU, and we are currently working on a project to overlap food deserts in Lake and Porter County and how that reflects with life expectancy. So we know that that's going to be a very strong correlation, but to have that visualized is going to tell our story better than we've been able to tell it in the past, specifically with policymakers and lawmakers, right? They need to understand how the work that we're doing is impacting the public health of our communities. We are also working with the IUN School of Medicine. Their future doctors are coming to work at the food bank to provide data support as well as volunteer support so that they understand how that connection goes from provider to social supports. We also work with the Gretchen Swanson Center for Nutrition on some data supports on our Food is Medicine work in partnership with Elevance Foundation. Now, I do want to share one really cool thing that we're doing. We are one of the few food banks in Indiana and one of the few in the country that has leveraged smart lockers. In Northwest Indiana, we currently have 4 smart lockers. Looks like an Amazon locker, except it's refrigerated. One of them with our FQHC partner HealthLink in Valparaiso is a Food is Medicine project. So that locker is open and available 24 hours a day, 7 days a week, so that a healthcare provider can have a medically tailored box of groceries for their patient that has 24-hour access and is refrigerated. It's been such a unique project. The challenge that we see at our food bank, though, is we know that nutrition matters, right? The challenge is calories are cheap, nutrition is expensive. And so what we need is sustainability for these types of projects. And there's a great way to do that, and that is through Medicaid and Medicare. There are some states that offer Medicaid waivers to make reimbursement eligible for social determinants of health, food being one of those. And that could be a process that the state of Indiana could use to make projects like these sustainable in the future. I'm really excited about the future. I'm so happy to see all of you sticking around to hear about all the great things that are happening throughout Indiana and here in Lafayette. But I want to leave you with this. Oftentimes people ask, how can you engage? And I think Kier did a great job of explaining how you can engage here locally. If you're in Northwest Indiana, we could use that same help. Look, I was talking with Holly about how we need help training our team on continuous quality improvement. At the end of the day, our food bank looks at ourselves not as a charitable food organization, but we see ourselves as a public health organization. Without quality nutrition, there is no public health. So the food bank system has to be a part of the conversation in anything that has to do with public health. And I would encourage you to partner with your local food bank, wherever that may be. Again, there's a food bank covering the entire country because they are here to help you. Thank you.
So hi, my name is Lynn Herr, and I am with Vanderburgh County Health Department. So I was telling Holly this when we got started. I do not have enough cards here with me today to everyone that I want to give them to because I got to follow up with them after I've heard them all talk. Working in a local health department with multiple hats, because not only do I help serve our home visitation program, but I'm the director of clinical and outreach, so I work with hepatitis C. I work with billing, all the way down to billing and how FFSA supports our community health workers. So I wear a lot of hats, and it does take a whole room of partnerships to make it happen at the local level. I'll just start with that. And I'll run through my program super fast. So everybody knows Indiana's maternal health outcomes and that our infant mortality rates are higher than our black population, much higher than our white population. But in Vanderburgh County, it's even worse, okay? So you can see there with just kind of doesn't project as well, but our blue line for our Hispanic families, you can see exactly when they moved to Evansville, Indiana. You can see exactly when emergency Medicaid and services are put into place, and you can see what happens to our infant mortality in our Latino families. But boy, it sure didn't happen for our black families, and it even got worse through COVID. Our home visitation program is to address the most vulnerable populations down in southern Indiana. Vanderburgh County has a problem. We are actually just moved from the second to the third, which is not that great, but the second highest in black infant mortality. Our home visitation wants to focus very much on those families. This is embarrassing to be the second highest. We shouldn't be there, and our community needs to understand that. Our pre to 3 home visitation is a different model than what you normally see, and I'll explain that model just a little bit going forth, but the focus is to build resiliency within our families and to reduce infant mortality. I will say, I'm very proud of this program. We have had 0 black deaths in our program since we started in 2018. And if you look at the outcomes for the rest of the population of those families that we don't get the opportunity to serve, obviously that is not where we want to do. But we want to improve our maternal-child outcomes, and that is fostering that parent-child relationship, building those bonds early on, building those that connectivity in their brain, a very early education to improve the education of those children and those outcomes for generations. We have absolutely no standard for coming into the program. We have no limitations. None whatsoever. So if a family makes less than $15,000 a year, which is almost 40% of it, if you can imagine living on that kind of income a year, is very difficult. But we've also had master's prepared women that are in our program that have had trauma in their background and know that they need support of community health workers, RNs, and clinical social workers to be able to help them out. Our model is community health workers. So in our home visitation program, we have 4 community health workers that are black. 2 of those are Haitian, which we have about 7,000 Haitian folks in our community right now. We also have 4 Latina who are very strong-willed, who actually have really pushed the envelope. We had a lot of providers thinking that emergency Medicaid only still addressed delivery, and we do that within not only our county, but make sure that the 10 counties that are in our preparedness district know that they get the same kind of health care as everyone else, and that's been a real struggle. They do have the support of nurses in the home with them as well, so they have that clinical support as well, as long as client advocates to make sure that they're getting food, that they have housing, that housing and food are health. All the screenings that we do, make sure that all of our families get all the resources for their children that they possibly need. Currently, we are serving, this is kind of an old slide, we hit the 250 mark. Back again, after COVID, we did take a little hit, but we're up and running again. And again, serving multiple families, and those clients move in and out, and you can see there, it's almost, I think we're up to almost 1,300 families that we have touched. This is where Purdue kind of comes in and helps us out. We do have a very robust documentation system, which we have over 300 data points, which we felt like was very important for our program. And because we are our local health department, there isn't that kind of bandwidth for us to look at all those. So Purdue really helps us look at our outcomes, and we are currently hopefully close to publication, and then also helps us with our community health worker billing to make sure that they are advocates for us, because our community health workers, when they're in homes, they can bill. We're one of the only agencies across the state of Indiana that is currently billing for community health workers, and I work very closely with Jen Wathall in the beginning to make sure that we were billing, but really they only get about $19 a visit. So there is a lot of work to be done around community health worker billing and being able to support those services. Just quick demographics, I'd be glad to talk about it with anybody, but about 70% of the folks that we serve are on Medicaid. We have about 30% that are Black. Within that, embedded in that, is about 15% Haitian. We have a 36% Latino rate, and we are serving the most vulnerable in our population. Just so you know, we do have a zip code, which we very much focus on, which is 47713. It has a Black infant mortality rate of 42. Let that sink in. That is bad. They have no grocery store. It is where our Black population is concentrated, and very much where we try to focus our efforts. And again, I will say, not a single Black death. So with support and community partnership, we can make this happen. When we first started this program, hardly any women were getting aspirin therapy for preeclampsia. Now we have a universal, everyone in the community is screening and giving aspirin therapy because what our program did to advocate for Black women. And we're planning on expanding. We've already expanded to one county. We just heard from St. Joe County that they're ready to look at duplicating these services. So if anybody would like to talk to us about that, please get a hold of Holly and her program, and we'd be glad to be able to have those conversations. Thank you.
All right, I'm literally the only thing standing between you and the end of the day now, but my name is Stephanie Long. I'm with North Central Health Services. We own a 16-bed inpatient psychiatric hospital located here in West Lafayette, Indiana. We also have a grant-making mission, and we grant roughly around $7 million annually to Tippecanoe County and the contiguous counties. And when I accepted this position and moved to North Central Health Services, I was really excited about the funding arm of our organization. What I quickly learned was that to grant for outcomes really was a thoughtful process, and it wasn't something we could do alone. It was something we had to have community partnerships for. And we're lucky, right? Purdue University is literally a stone's throw from our organization. So we revamped our grant-making process. We began to utilize our community health needs assessment, which is data-driven to identify our strategic priorities that we wanted to address. And then with that, we would begin to look at what organizations are available and within our region to help us address those specific areas. So academic partnerships became critical really early on. And one of those first partnership started due to the identification of a gap of mental health professionals in our community, which isn't unique to us. That's across the nation. And I was at a community meeting with the Dean of Health and Human Sciences. And maybe out of naivety, I said to her, would you ever think about starting a psychiatric mental health nurse practitioner program if you had funding? And she looked at me and said, well, sure. And I'm thrilled to say, within that small conversation, we provided that funding. They launched the program within, I believe, less than a year and a half. And a few short years in, they've graduated over 50 psychiatric mental health nurse practitioners, and the vast majority are practicing in our community. I mean, academic institutions can perhaps seem large and maybe daunting, but what I have found is they have all been extremely nimble and quick to react. Similar situation, that same dean connected me with the Dean of Health and Human Sciences at Indiana University, because we talked about the fact that there's a shortage of masters in social workers as well, and there is not a program located within our region. And again, through these conversations, we provided a grant to the Indiana University School of Social Work, and they will be launching a satellite program located on the Ivy Tech Lafayette campus this fall. So it'll make it easier for those individuals to attend that program, and again, we hope graduate, and regardless, we want them to stay in our region, but if not, they're staying in, hopefully, in Indiana, and a rising tide lifts all boats. Then the latest partnership really came as a result of Dr. Adams attending, again, a local community meeting, speaking to us, and I thought, gosh, I'd really like to sit down with him and just see where is his focus, what does he see going on in the communities, what initiatives are out there, and how can that maybe be a fit for North Central Health Services. About that same time, Indiana announced the Health First funding. And so that was heavy on our minds at NCHS because the vast majority of the counties we serve are rural. We know that the individuals serving in those health departments are small, limited numbers. They're doing the frontline work, and we weren't sure how we could help them, but knew that we wanted to try to find a way. At the same time, we were having conversations. I was sitting on the board of the Indiana Hospital Association, and there were a lot of conversations about, again, how can we support these health departments so that there's an impact with the health outcomes from this funding. And so had lunch with Dr. Adams and with Holly Wood, and again, in just really probably a few short weeks, we came up with the concept of a health equities initiative that will support Tippecanoe and the surrounding counties, help them in terms of hopefully providing them with things that isn't readily available to them within their health department, right? So data analysis, technical assistance, individuals to help connect them to evidence-based programs. So again, they're looking at where the gaps are and listening in those individual counties, and then helping them tailor their efforts to help move the needle. We know that may look different from county to county, right? Certainly Clinton County population demographics are different than Benton County demographics. But what this partnership does is helps fill the gap of expertise in certain areas where, it just may be limited due to manpower. And so we're definitely excited about that. And hopefully one of the things you've heard me say is I was sitting in a meeting by someone, right? We have found and are very grateful for the fact that many of Purdue faculty are involved in community organizations. And so that makes that ask and those casual conversations a lot easier. They're there, they're available, and they're listening and know where the needs are and know what's going on. So very excited about where this may lead, and I'm looking forward to seeing what happens in the next year and two. Thank you.
Thank you to all our panelists. As you can tell here, they have a theme that partnerships definitely are important and valuable in the work that we are doing if we're going to make an impact across the state as we try to address health disparities. I have a question for Lynn. Lynn, you are also engaged in the University of Evansville. Can you speak to this academic community partnership and give some examples of projects that you successfully partner with?
So Evansville just recently got a federal grant called Promise Neighborhoods, in which there are 32 agencies that, local agencies that are partnering together along with our Pre-to-3 program. University of Evansville is leading that program, in which we will again be focusing on our most disparate populations in 47713 and 47714 that are supporting our Pre-to-3 program, but then also developing with our curriculum, the Great Kids curriculum, really preparing those kids for their integration into preschool and into regular school in our most vulnerable neighborhoods, and then just looking forward down the line and thinking about how we're changing things generationally, those integrations into U of E scholarships to be able to let those children eventually go to college and along with the University of Southern Indiana.
Okay, thank you. Looking at academic partnerships across the board, what would each of you, what comments or suggestions do you have for our audience here on what's needed in order to be successful in that space in academic partnerships?
I think listening is really important. Again, while there are similarities in communities, there's always little different nuances. And in order to really provide them that boost where they need it most, it takes listening.
I'd like to add to that a little bit, if I may. Your voice is incredibly powerful. Incredibly powerful. Policymakers, legislators, they will listen to you. When we are advocating, Kira and I spent last year, we were in DC more than a handful of times. We're going to be there next week. When we're talking with our delegation, they see the food bank folks coming in, and they'll give us a handshake, and they'll listen to us. But they'll hear you. That's where you can really move the needle for us, because we're talking systems change. And we have to do the boots on the ground work, but while we're doing that, we need your help to change the systems, and that only happens with policy shifts.
I would like to add that as an organization, not to be afraid to reach out. I think half of our partnerships, we've been sought out, and half of them we've asked for as well. And I think also as an organization, being aware of your own capabilities. A lot of nonprofits are understaffed, and some of these partnerships really do take a lot of staff time. And so making sure that we have the capacity to also make sure we can see the project through and help out in that regard. Yeah.
And I will kind of just talk about it from a local health department perspective. Students expand our workforce. Getting other local health departments to understand that taking on interns and taking on graduate students is an important part of developing our public health system, expanding our services, and then also getting the youth of our state, our country, passionate about public health and wanting to help.
Some of you have, your programs may have been affected during the time of COVID-19. So specifically when that took place. So how did you address that, especially with data, to help drive your programming?
I can speak to this as a local health department. We had to shift, and we had to do virtual visits, and to help our folks. Again, we serve the most vulnerable, so they probably felt the most of COVID. Simple things like toilet paper. Everybody went out and bought up all the toilet paper in Evansville, and then our most vulnerable folks did. I mean, it sounds kind of funny, but it's not. Then we were out buying and trying to bring in toilet paper in from our homes and everything else to give to our families. The other thing around just being able to capture that data, one of the things that we did as a local health department, and again, it goes to partnership, is really standing shoulder to shoulder with our mayor, with our universities, with our 2 hospital systems, that we had a common message that went out as we stood together. We got together every Friday and talked on the phone and had that message that was all the same all the way across the board. And I think that that helped our community as a whole weather COVID maybe better than some communities.
So for the food bank system, I mean, we really, everybody was told to stay at home, right? We heard about the conversation and how that challenge was for the homeless population. We were in overtime. So as COVID's happening, we're working harder than we've ever worked. Our food bank, we were doing 1 to 2 food distributions through a mobile distribution a week. During COVID, we jumped to 6 to 7 a week. Oh. And to Kira's point earlier about the demand not going down, we're still serving 5 to 6 times a week. The demand has not shifted. So in answer to the question, COVID completely changed our business model, and we have stayed in that new business model.
Okay, yeah. There's some other, is there any other questions that someone has at this time from the audience? Do we have any? Okay. Well, we'd like to thank the panel for coming on and sharing with us about your academic community partnerships. Let's give them a hand.
All righty. Well, thank you so much for a great day, a wonderful day. Thank you to everyone who hung in there with us. Just want to recognize our poster award winners, and trying to pull that up. Want to recognize number 1. We have here Devin Harvey for Spanish language resource readability on ophthalmology websites, is one of our poster award winners. And the other poster award winner is Luke Brennan for HPV 16 DNA detection from endocervical cells with simple visual readout. I hope you all got a chance to walk through the poster sessions. If you don't, at least just walk by them on your way out. Some amazing work by our students, by our faculty to put those posters together, and just a tremendous display of the interdisciplinary nature of the work that's going on here at Purdue. I want to say thank you all for coming today and for sharing your time with us. I hope you appreciated the work that our team put into this day. As you saw last year, and again, we repeated this year, we tried to give you some national perspectives. We tried to give you some state perspectives, and I really want to thank Dr. Rosiniak for driving up here to give us a state perspective. But most of all, we wanted to give you a boots-on-the-ground local perspective, and because we know ultimately that's where the work happens. And so to all of our panelists, just truly amazing, amazing job. Thank you so much. This was a wonderful opportunity for us to celebrate the outstanding work that we all do together and to think big about how we can utilize Purdue's strengths to make an impact at the state, national, and international level in the health equity space. I want to thank CTSI for sponsoring the poster session, and I want to thank Dr. Collins. Oh, you've been amazing. I mean, truly, been here all day long. Thank you. It's truly an honor to welcome you here for Purdue's 3rd Annual Health Equity Summit, and next time we will have a guitar for you to play. To everyone, there will be an evaluation sent out via email within the coming days. I'd encourage you all to fill this out because our work is for you, and we want to make sure we are scaling up the good and that we're phasing out the things that didn't work so well. The slides and recording of the event will be posted to our website in the coming days. And finally, please reach out to me directly if there's anything I can do to support you in your professional journeys. Thank you again. This concludes our 3rd Annual Health Equity Summit. Happy Leap Day, and Let's change health in Indiana and our country and beyond. Thank you.